This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Acta Neurochirurgica, published in 2026, titled Effective Training on Navigated Frameless and Frame-Based Stereotactic Brain Biopsies, a retrospective comparison of staff neurosurgeon and trainee perioperative performance and complications.
This is a topic close to my heart, Alara. We're always balancing the mandate to integrate resident physicians early into a broad spectrum of surgical procedures with the absolute necessity of maintaining medical standards and ensuring patient safety. This study really digs into whether resident involvement in stereotactic brain biopsies actually moves the needle on complications or efficiency.
Exactly. The researchers conducted a retrospective two-center study looking at 217 consecutive patients. These cases came from Ernst von Bergmann Hospital in Potsdam and Regensburg University Hospital, covering a period from roughly 2017 through 2025.
And for our residents listening, the study categorized cases into teaching and non-teaching. Teaching cases were defined as those performed mostly by a resident in postgraduate years 1 through 7 under direct supervision, what's often called Level 2 supervision. The non-teaching cases were handled by the board-certified faculty neurosurgeons, or BCFNs.
Right. They looked at both navigated frameless biopsies, using systems like the StealthStation S8 or BrainLab, and traditional frame-based stereotaxy. The primary endpoint was the occurrence of a complication, specifically looking at intracranial hemorrhage, which the paper notes ranges in the literature from about 2% to 17%, depending on the technique.
So let's get to the million-dollar question. Did the residents have more complications?
The data says no. In fact, they tested the null hypothesis that complication rates would not differ between supervised residents and experienced BCFNs, and they failed to reject that null hypothesis. Out of 217 biopsies, the complication rates, which were all asymptomatic hemorrhages, were remarkably similar. We're talking 1.7% for the resident-performed cases and 1.9% for the BCFN cases.
That is a vital piece of data for training programs. It suggests that hands-on operating room training, which the authors regard as the most valuable form of education, can be done safely. It supports the safety of supervised early surgical education, even in procedures that involve perforating healthy brain and tumor tissue.
But Aris, while safety was comparable, the efficiency told a slightly more nuanced story, especially when we differentiate between frameless and frame-based techniques.
Let's dive into those secondary endpoints: operation time and anesthesia time. This is where the learning curve usually shows up in the data.
It really does. For navigated frameless biopsies, the mean operation time was actually quite similar: 38.1 minutes for residents and 44.7 minutes for BCFNs. The p-value there was 0.133, so no statistically significant difference.
That's interesting. One might expect the BCFNs to be much faster, but in the frameless world, the navigation setup and the twist drill hole workflow are fairly standardized. But what happened when they put the frame on?
That's where the BCFN experience really shone through. For frame-based biopsies, the BCFNs were significantly faster, with a mean operation time of 32.9 minutes for the residents compared to 47.5 minutes for the BCFNs. That resulted in a p-value of 0.047.
And the anesthesia time. That's often a better proxy for the total surgical footprint on the patient.
The anesthesia times followed the same trend, but were even more pronounced. For frame-based biopsies, residents took an average of 164.5 minutes of anesthesia time, while BCFNs only took 111.8 minutes. That's a significant gap, with a p-value of less than 0.01. Interestingly, the study found that residents completed frameless biopsies much faster than frame-based ones in terms of anesthesia time, whereas the BCFNs were actually faster with the frame-based procedures.
That makes sense from a generational and training perspective. Many senior attendings, the BCFNs, grew up with frame-based stereotaxy. It's second nature to them. Residents today are often more digital natives with neuronavigation. The paper mentions that the frame-based approach involves more manual steps, calculating coordinates, adjusting the arc, ensuring the entry point is exact. Those are manual check and recheck steps where a trainee will naturally be more cautious and slower.
It's also worth noting the hospitalization length. This was one of the more surprising stats at first glance. The mean hospitalization time was significantly longer in the BCFN group, 12.5 days versus only 7.5 days for the resident group.
Now, for the residents listening, don't go thinking you're better at discharging patients just yet. How did the authors explain that?
They attributed it to selection bias. This was a retrospective study, not randomized. It's highly likely that the BCFNs were taking on the more complex cases, patients with significant comorbidities or higher perioperative risks, which naturally leads to longer hospital stays. The residents were likely assigned the more straightforward cases, if there is such a thing in neurosurgery.
Exactly. It's the hidden hand of the attending surgeon. We select the cases that are appropriate for the trainees level. The study even noted there was no significant correlation between the resident's specific year of training, PG 1 through 7, and the perioperative parameters. This suggests that the level of supervision is the stabilizing factor. Whether it's a junior resident or a senior one, the BCFN is there to ensure the complication rate stays at that 1.7 to 1.9% level.
The study also touched on why this matters right now. They mentioned the European work hour restrictions. With less time in the hospital, every minute of hands-on training in the OR becomes more critical. If we can prove that resident-led biopsies are safe, we can justify keeping them as a staple of early training.
And it is a staple. Brain biopsies are essential for establishing pathological diagnoses of tumors and inflammatory conditions. As the paper says, it's an essential technique for a neuro-oncology expert surgeon to master.
I found the technical details in the method section quite robust. They described the navigated biopsy using the Veritac or Vario guide systems, and the frame-based approach using the Reichert-Mininger or Zamorano-Dujovny frames. They even mentioned the use of intraoperative frozen sections to confirm diagnostic tissue was obtained.
That's a key point. If a resident is doing the procedure, they are still following the full safety protocol, pre-calculated trajectories that avoid sulci and vessels, sharp dural opening, and coagulation of the cortex. The study shows that the surgical craft of the biopsy, the actual passing of the needle, is being taught effectively.
To summarize for our listeners, the study found that while residents do take significantly more time for frame-based cases, both in terms of operative and anesthesia time, their complication rates remain identical to those of staff surgeons.
It really validates the current apprenticeship model. It shows that as long as there is direct BCFN supervision, we aren't compromising patient safety to train the next generation. The null hypothesis holds. The resident is just as safe as the attending, even if they need a little more time with the stereotactic arc.
It's a reassuring conclusion for medical students looking at the field, and for residents who might feel the pressure of the clock in the OR. Safety first, speed second.
Well said, Alara. That's all the time we have for today's deep dive into Acta Neurochirurgica. To our listeners, keep honing those stereotactic skills, and remember, the data is on your side.
Thanks for joining us on the Neurosurgery Hub podcast. We'll see you in the next episode.